Hello, thank you for the introduction. It's a privilege to speak to everyone today about a topic that's really near and dear to us here at the National MPS Society, and that's leveraging partnerships to create a successful newborn screening program for MPS. I've been with the National MPS Society for about 11 years now. A little bit more of my background is I've been a member for 20 years because our daughter Jennifer has mucolipidosis type 3, and it's one of the diseases the society supports. I also have a really good opportunity being in a patient advocacy group to not just give you bullet point slides, but be able to share with you as we walk through leveraging partnerships a lot of pictures that tell stories about what we've done to create our newborn screening program over the past 2 decades and why it's been successful. So I hope you enjoy that type of presentation, and I'll do a summary between sections and at the end as well. But first, let me talk a little bit about our organization. The National MPS Society has a mission to cure, support, and advocate for our diseases that we support, which is MPS and ML. And my hope is that throughout this presentation, that I'm going to be able to give you teachable moments that include some ideas and strategies and takeaways that will help your patient advocacy group, or you might be able to share with a patient advocacy group that's in this space to cure, support, and advocate. Here's a snapshot of the diseases that the National MPS Society supports. So you understand that we are an umbrella organization. We serve 11 syndromes in the lysosomal disease space of the MPS and the ML. And in the ML side, we include the eye cell disease and pseudohurler polydystrophy. And I wanted to give you a glance at our organizational profile. I didn't do this to intimidate you in any way at all. It's more about who are we, and then how did we achieve what we did, and what does it look like? But regardless of where you are in the timeline of your organization, know that there's going to be some takeaways that everyone can benefit from. And we hope that this will at least allow you to see how we've grown, and because of that growth over the past 4 years, what we've been able to do differently than we did 20 years ago. But we're a 45-year-old patient organization, and we've grown in the past 3 years from 700 household member to over 2,100 active member households. And part of that's because of the advocacy work and the newborn screening work that we're doing. We also have a Pathways program, and that is a program where we have our social workers meet with newly diagnosed patients around the country. And then we've also had an established 20-year legislative advocacy program as well. Some of our board members live on Capitol Hill, and we actually do have hub space there with every life solutions, so that we can do Capitol Hill work, and that's been very beneficial for us. We currently have 5 approved therapies for 11 of the diseases that we support. We are governed by a board of directors, and we have a scientific advisory board that oversees our research program. So let's talk about building a newborn screening program, because the newborn screening program that we have at the National MPS Society has multiple directives. It's project management and it's strategic management, really at the highest levels. The goal is to screen for MPS disorders. That's the goal. Unpacking the project and building the multiple directives that are layers of the project are key, so that we can ensure that the efforts that we're doing are able to run in tandem with one another. And so what I'd like to do is start to unpack the program for all of you. First, for the National MPS Society, it was important to identify key stakeholders in the newborn screening program, because we're in project management to save lives. Identify the key stakeholders, know your patient community, and then build directives for the program that you can initiate. Many of the individuals in the groups that you see in this circle are stakeholders, and some of them are real direct stakeholders. And we know this. For instance, the child. The child is the first and the most important stakeholder with regard to the screening process itself, since it is the child's interest to have the program. The importance to the child is why messaging to the parent should not be opt out of newborn screening, but instead to opt in, even if they have choices and subsequent choices not to opt in to keep the samples for future research. The family is our second stakeholder to the newborn screening program. Since they are the caregiver and the rare diseases can be devastating for the family ecosystem, they most certainly have a stake in the game. Also, one item that continually comes up with our parents is that the use of the residual dried blood spots can have implications for the privacy and identity of family members. When parents attend meetings about the use of residual dried blood spots, they do express concerns about how the use of those samples will affect not only their children, but perhaps the entire family or other members of the family. At the Society, we do emphasize the importance of the dried blood spots for future research, and we encourage families the critical need to capture these. I'll share a little bit more about this later in the presentation, but I wanted you to know that it was a concern. Parents are a stakeholder. We then have to look at our scientists and our clinicians and how do they fit into the newborn screening program at the Society, because they're stakeholders too. For researchers, the use of the residual blood spots for research is important because their job is to use this important resource to generate new knowledge in ways that will help all children and families. For the physicians, this is lifelong management. This is lifelong care and management once a diagnosis has been made. So ensuring that newborn screening is presented back to the physician or the primary care physician so that the family is delivered this information in the most sensitive way and a plan of action can take place in terms of what therapeutic options may be available and choices the family can make, the physician is a key part and is a key stakeholder. Government and the public health departments, they're also similar stakeholders because they are stewards of this important resource. Taken together, these are the primary stakeholders. But you'll also see on the perimeter that we have some other key decision makers too, like the patient advocacy organizations or the payers or the legislators. And we'll talk a little bit more about the ACHDNC. So when I talk about the newborn screening program at the National MPS Society, I talk about directives, I talk about project management, but I talk about it in terms of a couple of things that were the most important to deliver to this presentation. And that really is around the RUSP nomination and what is that like and how do we architect a RUSP newborn screening timeline. And the second part will involve the legislative advocacy work of the National MPS Society. But you'll see throughout the presentation that the patient and family stories are key and critical. They're the thread that's woven between both the RUSP nomination and the advocacy work that we do at the Society. Because without the patient stories and without those key stakeholders of the child and the parent, we're not going to go anywhere. Presenting a nomination for newborn screening is completed on the RUSP form, the recommended uniform screening panel. Here's a glimpse at the National MPS Society's process timeline that I've put together for you, and the introduction of directives on how the patient and family story is fully integrated in every step, in between steps, and all around. The slide here that I've put is really significant because it shows you that everything we're doing between the RUSP nomination, building an expert MPS team, advocating and networking with our key legislators, going through the entire review process with public commentary, and all the way through the evidence-based review, we are incorporating the patient and the family story. When we're designing the RUSP nomination, one of the factors that we learned and one of the lessons that we learned, and we'll go over lessons learned later, but one that we can talk about right now is how important it is for a patient advocacy group to be involved in a pilot program. And we were able to do that for MPS1 in the state of North Carolina. The National MPS Society sponsored the pilot program here, and the information from 80,000 screenings is now available. The pilot programs can be essential for providing the data to state health officials and prepare the agenda for those legislators to consider newborn screening. This is a good example, a really good example of how patient advocacy groups can advocate for critical studies. This is exactly the space that we belong. So when we're working on the RUSP nomination and we're talking about this directive of the RUSP for newborn screening under our program and under umbrella, it's important again to identify and drill down who are our stakeholders and always identify the gaps. I love it when we do things really well, but what keeps me up at night is where are our gaps and how do we fill that unmet need? What are the roadblocks? What are the obstacles, the barriers? That's what you have to start to really focus on to make sure that you can get through this process. This is not a sprint. This is a marathon. Newborn screening is a marathon. And it seems that it's working in counterproduction to what we really want it to be because we're trying to save children's lives, and that's a sprint. But the processes we have really are ones that make us be in a marathon. So we don't have an opportunity to really sprint all the time. We have to save our energy and we have to really just hunker down and prepare the best that we can. So here are key stakeholders. We have HRSA, which is the Health Resources and Service Administration, and under HRSA is the ACHDNC, which is where the nomination is going to be reviewed and presented, and that's the Advisory Committee on Heritable Disorders in Newborns and Children. We always want to identify who our key stakeholders are in these two groups and build relationships and understanding so that when we're putting forth the RUSP nomination, we're doing it in the most thorough and tight packaged way. So we're not wasting time. That's very important. I wanted to give you a glimpse of what the newborn screening process looked like for us when we submitted our first nomination back in 2012 for MPS1, and then what it looks like today, because just last month we submitted the nomination for MPS2, and we're moving forward with that nomination. It's in the review process right now. A lot of my slides next are going to focus on the MPS1 from lessons learned and how we became a better newborn screening program, I feel like, under the National MPS Society because of lessons learned. But I really wanted to focus on the fact that it's taken us 8 years to move forward with MPS2. And this really showed us how we have to embrace, whether we want to or not, how slow some things can be at the government levels, but the patient advocacy group still has to push forward. MPS1 newborn screening's nomination, as I mentioned, was presented in 2012, but it took the panel till January of 2016 to have it approved. This is where it was important for us to build a real MPS expert team, an expert team of both scientists and the physicians to wrap around the patient advocacy group so that we can ensure that the portions of the nomination that need to be filled out and considered for newborn screening are done at the highest level. This is not something the patient advocacy group does on its own. This is about building relationships with your scientific advisory board, with your care physicians, the people that you've built relationships over the years, whether they've been at family conferences or you've met them other conferences around the world. Bring your best team together, identify who's going to be in charge of what sections, and begin working on the process. I can share with you that the nomination for MPS1 took over 18 months for us to carve and finalize, and the MPS2 took about a year. What was sobering for all of us was that it took 2 years and 9 months till we had a final approval. We had no idea that it would really take that long. And it was hard because our MPS1 children were being missed in the diagnostic process. And we knew that we had life-saving therapies. It was a nail biter. It was hard. There was a lot of anxiety around it. In the end, we did learn a few lessons. We learned that the patient stories are important. We learned that during the public commentary and the opportunity to be in Washington, D.C. during the hearings for the nomination were critical. We have to know that we have to have experts inside of the room so that important questions are being fielded and facilitated properly so that the wrong information isn't being cycled. That's really important. We weren't prepared for that during the MPS1 nomination. And I remember at the time, our president, Steve Holland, had came out of that meeting and he had called us and said, I am really nervous. Well, in 20 years of knowing Steve Holland, I have never heard him say that to me. And he was so nervous because he wasn't sure which way the approval was going to go. Were we going to be approved or were we not going to be approved? Regardless, what he learned and what he shared with me is that we did not have the right experts in the room. So let's talk about the RUSP approval, long-term investment to cures. This is our wrap up. This is where I want to be able to share some lessons learned. Prepare directive timelines. Treat this like project management for newborn screening. Assign key stakeholder roles. Understand all the testing mechanisms, outcomes, and variability scales. Identify your obstacles and barriers. Provide enough research and development for supplemental communication. You have to incorporate your team with accountability strategies. Prepare the public commentary, response team for nomination reviews, and be present for all public hearings. Recognize that ill preparation can set the team back months, if not years. The RUSP approval for screening provides a guide to states to screen for MPS1, but each state is responsible for their legislation, state health lab infrastructures, and the funds to support the efforts. Are we done yet? We're not done yet because we have newborn screening for MPS 1, but there's still work that needs to be done and lessons that have to be learned to improve newborn screening. This screening began, and we found out pretty quickly we needed to create some new identification pieces. We needed to be able to do some identification and some studies surrounding the current methodology for MPS 1. All newborn screening for mucopolysaccharidosis MPS 1 is carried out by the measurement of something called A-iduronidase, or IDUA, which is an enzymatic activity in dried blood spots. The majority of the low enzyme results are due to the pseudodeficiencies. And the studies from the Mayo Clinic have shown that the false positive rate can be greatly reduced by including a second-tier analysis of glycosaminoglycans, or the GAGs, in the DBS as part of the NBS. In the study the National MPS Society participated in and just published this week, we obtained a newborn DBS from 13 patients with severe MPS 1 and 2 with attenuated phenotypes. These samples were submitted to 4 different GAG mass spectrometry analysis in a comparative study. This study ended up supporting the use of second-tier GAG analysis for newborn screening, especially the endogenous disaccharide method, as part of the newborn screening to reduce the false positive rate. Here's an example of newborn screening going forward in the States, but over the past 2 years, the National MPS Society as a patient advocacy group has been working deep in the weeds with our scientific and research team to collect blood assays so that we could put together this information. Let's talk about patient advocacy organizations and policymakers, because that's the next key part of what we're going to do. All along the way, while we're filling out the RUSP nomination, we are doing advocacy every day and everywhere. Patient advocacy group collaborations. We look at legislations like Newborn Screening Saves Lives Act. We are looking at securing bipartisan legislation for rare diseases. The Newborn Screening Saves Lives Act authorizes a modest amount of funding to help states expand and improve their programs. Also provides needed educational materials for families too, and improves follow-up care and treatment of newborns who screen positive for a treatable condition. When we hear that type of legislation, that's the kind of legislation that the National MPS Society is going to stand behind. We can't talk enough about newborn screening. We work on the federal level, and we work on the local and state level. But we want to build a progressive and a successful advocacy history. And we want our families to be part of making a difference. The Society has had years of an advocacy committee. It's referred to as our Legislative Advocacy Committee. And our constituents share newborn screening with senators and congressmen across the country. We have developed a Speakers Bureau program where we train our families to share their stories and come to Capitol Hill during Rare Disease Week, during MPS Awareness Day, at the local level in town hall meetings when decisions and key decisions about newborn screening is important. I wanted to share this other slide with you. I wanted to share that even back 10 years ago, this was the patient advocacy viewpoint from the National MPS Society, and not much has changed. I just wanted to share this slide to show you that we were talking about these things 20 years ago. We wrote them down 10 years ago, and these things are still true for us as an organization. So really figure out what the focuses and the goals are for newborn screening, and then try to stay true for it, and then be nimble and pivot when you need to do so. You need to be present for the families. If you're asking your families to go to the state level and to work with their legislators and their congressmen with newborn screening topics, you need to be sure that you're there. This is one way to not only get involved and get to build your networking relationships with congressmen and senators, but you're supporting the families. And there's always a source of anxiety, or maybe they're nervous about sharing their story. In the end, most of the time, there's hardly a dry eye in the room by the time they're done talking. And we've just enjoyed this experience very much. And we're certain it has led to some of the states screening for MPS 1. The patient testimony is key. How important is it? I wanted to share this slide with you because if I don't share it, I'm doing an injustice to newborn screening. On the left is little Lauren, and she didn't make it. This was many years ago, and her mother formed the National MPS Society. She was one of the original founding members of the society, but she was the founding board of director member all the way back in 1974. And her daughter passed away. Here we are today because we have newborn screening for MPS1. Families have an opportunity to have transplant or ERT therapies, and the impact of intervention is considerable. The diagnostic odyssey is incredibly painful, even today, and some patients and families wait years for a confirmed diagnosis. We have 22 states, if you saw my last slide, that are screening for MPS1. We're only halfway there, and the legislation was approved in 2016. So you can see again how this is a marathon. It's not a sprint. Grassroots and statewide advocacy programs, every day, everywhere. Take the opportunity for your patient advocacy group, or if you're working with a patient advocacy group, to know that you can attend key stakeholder networking meetings and you can create speaker bureau programs. We brought over 70 families with us earlier in the year before the pandemic to Capitol Hill. This is what we do, 90 meetings with congressmen and senators. Building legislative relationships, both at the state and the federal level. When you have a key federal senator, working on Capitol Hill, who's well known and comes to champion you in your rare disease space, well, you certainly take the time to acknowledge it, and you certainly take the time to make sure that he hears what your real unmet need is. And for us, it's newborn screening. But it doesn't just stop with senators and congressmen. Part of our advocacy work has to do with the work that we do with the FDA and the NIH. One of the other areas for our newborn screening program and research, just research in general, is to ensure that the different departments of NINDS and NIDDK and NICHD and NINDS, ORDR, and NCATS, they recognize mucopolysaccharidosis. They understand and they've heard the word MPS. And so we work very hard at the Society of putting together appropriations language that's going to increase the amount of federal funding for these diseases. We have had the appropriations language with MPS research inserted into the bill, and when we have doubled the amount of funding for research. But this just is just another platform, another directive within the advocacy platform that we have for newborn screening that says we need to make sure that everybody knows what MPS is and what newborn screening is. But everybody needs to know about MPS. And we want the FDA and the NIH to be involved with patient advocacy groups at this level. Successful newborn screening provides a child and their family an opportunity to live a healthier and significantly higher quality of life. Charlie made it through. He was screened. He had a transplant. He's doing fabulous. This is what it's all about. Now that we have newborn screening for MPS1, our Pathways program is exponentially seeing infants at the time of diagnosis. And they're immediately going into therapies and treatment options. They have treatment options, and they're having therapies sometimes less than 1 month old. That is incredible. So what are some of the lessons learned from building advocacy and years of strong relationship building with our legislation, our legislators, our congressmen, and our senators? Have a program that builds grassroots and federal advocacy programs. Have a program that builds those secondary tiered programs. Be knowledgeable of the key states with screening decisions. Help families to share their stories and help them give meaning to a difficult experience in diagnosis. Work with other foundations, the Every Life Foundation, NORD, Global Genes, etc. You don't have to do this lift alone. Some of the best collaborations and partnerships is when we brought foundations together on this key issue for newborn screening. Provide testimony to fund state labs and infrastructures. Don't forget about it. Think about the key stakeholders again, back at that first slide that I talked about. Our state health departments, they're stakeholders. Providing testimony can help fund that area, which is critical. That's why we don't have all the states funding yet. We don't have the infrastructures built because they don't have the funds. Hold webinars to engage with grassroots advocacy. Provide action alerts to members and donors on key legislation for newborn screening. For instance, the Newborn Screening Save Lives Act that I mentioned earlier. Collaborate with our patient advocacy groups and communicate, not just on social media, I have it here on the slide, but communicate everywhere, broadcast. So as I move into global networking in the summary of the presentation, I wanted to share with you one thing that is really important to know. The National MPS Society works on an international level as well. I'm the co-chair of the IMPSN. We are very fortunate to be in the country that we're in the United States. Very fortunate. The perspectives, excuse me, that are provided to us in the international community and amongst each other when we're networking are crucial. We're able to bring back perspectives to key stakeholders in the newborn screening program here in this country that we may have never known. If you have an opportunity to network on a global level with your patient advocacy community, or your patient community, I should say, do so. Same thing with the global foundations. Global MPS foundations in pursuit of a cure collaborate with one another, and we're stronger when we're able to work together. Newborn screening is one of those areas where we work better together. This was all about leveraging partnerships to create a successful newborn screening program for MPS. I went through a lot of slides. I really focused on the RUSP nomination. I focused on our advocacy work. I focused on the patient stories, but let's take a look at the summary to make sure I didn't miss anything else. Educate on newborn screening, patient needs, early therapeutic access, importance of the dried blood spots. Identify your key stakeholders. Begin building relationships now. It's never too soon. Actively advocate for newborn screening coverage of conditions. Provide patient story platforms, testimonials, and give your families tools to use. Help them come up with their stories so that they can carve them out. Understand the RUSP nomination process and identify who can be on your team. Broadcast communications in multimedia formats. Survey your patient community, identify the gaps in newborn screening program. Work on both the local and state and federal levels. And leverage collaborations with industry, physicians, hospitals, patients, and other patient organizations to increase newborn screening success. Remember, I've said it twice, here's a third time. It's not a sprint, it's a marathon. But if you plan right, it'll be successful. Thank you.